Good afternoon, everyone. Thank you for joining us for DDU Viva practice. If you're doing the DDU this year, it'd be great if you might be able to put your cameras on, because I'm going to ask you questions. If you're not, you're more than welcome to turn your cameras on or off. But if the camera's on, I'm going to ask you questions. Can I first of all just show you something exciting that happened this week? So Tara, our admin person who sorts out everything for our education centre, made this amazing QR code for the Echo at Nepean, which has got a little heart in the middle of it as well. So I think that's one of the cutest QR codes I've ever seen. So I was pretty happy with that. We also hit 10,000 followers on our YouTube channel this week. So for any one of you who are following us, I appreciate it. And in memory of that, we've got our new QR code, which I thought was very cute. Okay, Drew, do you want to kick off first? So case number 1. Everyone, hold it. Rohit's first time. You happy with the happy with the way the DDU Vivas work? Do you need me to go through this again?
And STEMI patient review the following images. Describe the regional wall motion abnormalities in the coronary artery. Okay. Yep. So when we talk it through, hey, personal long axis view, hypokinesis, and maybe some thinning in the inferior lateral, basal inferior lateral, and maybe more basal inferior lateral in this view.
Happy to move on.
Yeah, so it's circumflex potentially. So short axis view. Again, in the inferior, there's hypokinesis in the inferior. Mid-inferior wall. This is kind of like a PDA, posterior descending artery, depending on the dominance. Continue. Okay, so 4-chamber view. Yeah, so it appears globally dilated. The LV appears globally reduced, but you're not asking me that. The basal septal, I think, is akinetic.
Basal septal.
Sorry, inferior septal. My apologies.
Okay, nice.
And I think the basal free wall of the right ventricle is reduced as well. I'd want to have a focus view, but it's making me think of the right coronary artery. Continue. Again, 2-chamber view. Again, so it's the inferior wall looks hypokinetic.
Yeah, and any basal, mid, or apical?
Sorry, basal and mid, from what I can see here.
And then
more
the last
basal.
one.
Yeah, so again, it's the basal inferior lateral region. So I think it's a posterior descending artery territory, regional coronary artery distribution. I think it's probably more RCA territory. Yeah.
Nice. So I'll take that. I thought that was excellent. So the only thing that's missing is so beautiful, no pauses or no errors in what walls you're looking at. That's absolutely what that case is all about. To be honest, if you're saying it's akinetic or dyskinetic, to be honest, I think that would be cherry on the cake. So I thought they were akinetic rather than hypokinetic. Clear pass. But it wouldn't be a pass well because you didn't tell me about the chronic versus acute.
Okay.
So tell me, so that's where the prompt would probably come in, which might be the thing that would have knocked you back a little bit. So tell me, how do you tell if it's acute or chronic?
Right. So in determining acuity, or basically in a patient with a chronic infarct, you'll see scarring, and thinning of the wall. You may see some dyskinetic portions and even aneurysms.
Nice. So what do you think this one is?
Look, I think in the inferior lateral wall that it is thinned. I think this is chronic.
Yeah, very nice indeed. So that's just the next thing with the regional walls. You've got all those walls sorted out, beautiful. Just make sure you take us to that next level, And to be honest, if you said it probably like that and it was just a pretty simple prompt and it was the first case, we'd probably put that as passed well, to be honest. Nice. Cool. Rob, you next?
Sure.
Okay, case 2.
So 56-year-old man collapsed at home, past history of heart failure, in ICU for dobutamine and noradrenaline infusion. Describe your findings. Okay. So this is parasternal long axis view. I'm concerned about the LV systolic function. Both the anterior septal and inferior lateral walls appear at least hypokinetic. And in that setting, the mitral valve is not opening well. The left atrium appears dilated. The aortic valve, although this picture might be slightly overgained, appears calcified, and there appears to be reduced opening of that aortic valve. I'd like to interrogate it from other angles. The right ventricle appears normal size. I can't really comment on its function at the moment.
You happy to go on?
Oh, yes, sorry, happy to move on. So the top left-hand image is a zoomed-in view of that aortic valve, and again, it's not opening well. I can see on the color Doppler across that valve that there's significant turbulence within the ascending aorta, which would occur with aortic stenosis. And then looking at the short axis view of the aortic valve, you can see that it's heavily calcified, and it looks like probably is a trileaflet valve, although I'd like to look at that zoomed in and from other views, and the significant restriction in its opening, and I'm concerned about significant aortic stenosis here.
Excellent. You happy if we move on?
Yep, happy to move on. Okay, so the top left-hand image looks at the parasternal short axis. The LV is significantly impaired. I'd probably say severe LV systolic dysfunction. There appears that there may be regional wall motion abnormalities from this view. So the anterior septal wall appears akinetic in this view, whereas the remaining walls are hypokinetic. Looking at the apical 4-chamber view, the LV appears dilated. Again, it's severely impaired from systolic function perspective. The inferior septal wall here appears hypokinetic, and it also appears like there's maybe even some paradoxical septal motion. The remaining walls, so the anterior lateral wall, is hypokinetic, and the overall function, like I said, is impaired. This is concerning because patients with aortic stenosis would normally have preservation of their systolic function, but when it's been severe for a prolonged period of time, they can have dysfunction. Biatrial enlargement, I can't really comment on the function of the RV, although it does look like the longitudinal function may be impaired. I'd like to look at it in a focused view, and we can move on. So this is a continuous wave Doppler trace across the LVOT. The maximum velocity across that valve is 3.2, which would put it in the moderate range, and the mean gradient is only 24. However, as already commented, the LV systolic function is severely impaired, and so I'd be concerned that it's unable to generate the maximal velocity that would be associated with severe aortic stenosis. Did I mention the DSI is less than 0.25, which would put it in the range of severe aortic stenosis, and the aortic valve area, which has been calculated, would also put it in severe range.
What would be the other values to determine severe AS?
So we've looked at maximal velocity. So normal would be severe would be greater than 4 meters per second. Mean gradient greater than 40 is severe. DSI less than 0.25, and aortic valve area less than 1, or index less than 0.75.
Okay, so these are some other images, and you just need to describe how each of the values in that red box are derived, please.
Okay, so the stroke volume is derived from the VTI from the LVOT trace. So that calculates the stroke distance, and then we can times that by the cross-sectional area of the LVOT, and that will give us a stroke volume. The aortic valve area is then we can calculate that using the continuity equation. So we know the stroke volume through the LVOT. That has to be the same stroke volume that goes through the aortic valve, and we can therefore use arithmetic to figure out what the narrowest area is, which will be at the aortic valve. So that's by the continuity equation. The body surface area is the aortic, that same value then divided by the body surface area, which is determined by the height and weight of the patient. And then likewise, the stroke volume, which has been indexed, is based on that, is divided by the body surface area.
And excuse me, sorry, silly question. You said about the LVOT area. How do you measure the area?
Sorry, it's you measure the diameter, you square it, and you times it by 0.785.
Fantastic. And where do you measure it and how?
So you would measure it in the parasternal long axis view. So I would zoom in and I would measure it at the insertion point, just proximal to the insertion points of the aortic valve.
Beautiful. So
inner edge to inner edge, and I would measure it mid-systole.
Fantastic. Yeah, great call. Well done. And so what is your conclusion at the end of this on the severity of the aortic valve stenosis?
So there are many indicators here indicating severe aortic stenosis. So it's the paradoxical low flow, low gradient, severe aortic stenosis in someone.
Isn't it just low flow, low gradient?
Sorry, low flow, low gradient, severe aortic stenosis in someone with impaired LV systolic function.
Good job. Excellent. Well done. Very nice. Very nice. Well, that was excellent. Just minor things to pick up there. That was a definite passed well for me there. You talked about being concerned about the left ventricle. I think with our language, I don't know how if this not pass or fail, right? You know, I think try and keep the language tight. You know, of course, we're concerned about it, but you said it on the next one. You know, it's like saying significant LV's systolic dysfunction that you said for the apical 4 one. I mean, it's moderate or severe. Take your pick. It would be either of them would be fine. I agree. I think it's severe. So just say, you know, this is severe, abnormal. Just make a call.
Okay.
I think it's worth mentioning, you know, we talk a lot about oh, you said it was global hypokinesis here. Just for me, I think we're dealing with an akinetic anteroseptal region there. I think the rest of it is hypokinetic. I think we saw that again. And again, this is regional wall. This is not pass or fail. Maybe it's just my own areas. You know, our short axis here, I think really clearly shows that we're akinetic, and you called it akinetic and then changed your mind when we looked at the apical 4. Yeah. So remember, the reason why I love the short axis one is because often it's harder to mess up, but also because you've got some of those regional walls, or most of the segments are in axial plane rather than the lateral plane. And if we're looking for thickening on the lateral plane for the apical 4, you know, you sometimes miss that movement of the endocardium. So I don't have any evidence to back this up, but I feel I've got a lot more confidence looking at that short axis view for the regional wall motion abnormalities versus the apical views, but minor stuff. The only thing I think which would again have stopped you from getting full marks for me was just mentioning about the you mentioned the septum. I think the septum is pushed over a little bit. It's got a bit of a wobble to it that might have been nice to mention, and we've got this interventricular conduction delay. Just, I mean, we talk about, you know, seeing the whole heart. You know, this guy with that septal abnormality, you just got to recognize that you can sometimes get some wobbles and what might appear to be regional wall motion abnormalities when you've got that interventricular conduction delay.
Yeah.
Amazing. Great job. There's definitely going to be a valve or two in this, right? You know, I think it's in the written as well as the Viva. You know, you're expected to know the valves at just that level that you're doing. You know, we're probably not going to give you a valves. It's just completely barn door. you know, having an idea about, you know, another question could be, where would you go from this patient? What would you do? How old was he again? Do we say it was 56-year-old man? You know, what do we do next might be a nice question to ask. What do you think about that?
Well, yeah, it's concerning because because of his severe LV systolic dysfunction, whether he will actually improve function after repairing of the valve. But I would discuss with my surgical colleagues and cardiology colleagues about best approach for opening this up, whether this would be surgically or via TAVI, and we think he'll get benefit from that.
Yeah, really nice. And so how can you try and tell if he's going to get benefit from that?
So what they'll do is they'll do a low dose dobutamine stress echo, and if he has recruitability of his myocardium with that, then it implies that with fixing of the valve, he may have improved function.
Yeah. And so just remember again the clinical context. So this guy's come into hospital having collapsed at home, and he's already on dobutamine. Yes. And I could have, if I were to rewrite this, I'd probably give you the doses in there, and I'd put something like, 10 mics per kilogram, dobutamine per min, and noradrenaline would be moderate. So, on a decent level of catecholamines. Yeah. So you're already doing a stress test. But in the clinical context, you've got to find out what else is going on. There are a million reasons why this guy could have collapsed. I've given you no other information. So I just, I think just again, the clinical context is key. He's having an exercise stress test at the moment, or a dobutamine stress test. We'd have to try and see how he goes through this. I don't think anyone would do an emergency. Oh, forgive me, I don't work in a cardiac center, but I wish I did. But I imagine they would not be doing urgent TAVIs or urgent aortic valve replacements in these kind of patients. They'd be wanting to see how they go and recover, and then reassess them in the cold light of day. Those kind of conversations. I don't think, again, anything you said would have been right or wrong, but just having a decent answer that involves clinical context and sensible doctoring is probably what's needed.
You'd be surprised some of the conversations we have, Sam.
Awesome. So it's exactly the same as with other areas. Rock and roll. Rohit, you want to have a crack at this one? So each Viva will have one question that will be along these lines, point and shoot. It'll say point and shoot, and each slide is a different patient. Cool?
Okay. Yeah. All right. So this looks like a parasternal short axis view focusing on the RV outflow tract. And we've got a pulse wave Doppler trace. Sorry, is this the descent? Yeah. No, so we've got the pulse wave Doppler trace just at the level of pulmonary valve, and we've got an RV outflow tract trace, and we are measuring the pulmonary valve acceleration slope. So any value less than 100 millisecond, I'll be worried about pulmonary hypertension. So it's basically concerning for increased pulmonary vascular resistance.
Any other information that can be gleaned from particularly the profile of the Doppler?
Yeah, so what we're seeing is we're seeing a notching at the peak of the wave, which is also known as a flying W sign. Resistance can lead to obliteration of flow before it continues. So that's another sign.
Of what?
Of increased pulmonary artery pressures, increased pulmonary vascular resistance, or severe pulmonary hypertension. Yeah.
Very nice. Very nice. Okay.
Yeah. All right. So we have here. So we've got a subcostal view in a transthoracic echo, and it looks like we've got a pulse wave Doppler profile. The image is moving very slow for me, so I can't really see where exactly the gate is. But I'm assuming
it's in the hepatic vein.
Hepatic vein, yeah, perfect. Yeah. So I'm assuming it's a hepatic vein Doppler profile. And what we're seeing, so with the ECG, so we're seeing systolic reversal of flow. So we can see some flow above the baseline, which basically represents the reversal of flow. And then the diastolic flow is normal, which is towards the IVC. So this would again be concerning for increased right-sided pressures or severe pulmonary hypertension or severe tricuspid regurgitation, but essentially right atrial pressures are severely increased.
Thank you very much.
All right, so we've got what looks like, so it's a transthoracic echo, apical 4-chamber view, focusing on the mitral valve. What we are seeing is a continuous wave Doppler profile through the mitral valve. Now, looking at the image at the top left, so and the velocities are, okay, yeah. So I'm seeing a flow convergence zone on the color wave Doppler profile and on the continuous wave Doppler profile. So again, the profile looks quite full, but not very dense. So I'd be concerned for moderate mitral regurg here. Okay. Doesn't look like severe. The mitral regurgitation jet looks like it's almost reaching the posterior LA wall, but the profile is like, it's not looking complete and it's not looking very dense.
Tell me more about the LV function. So the question for this one is, what information about LV function can be estimated from the Doppler profile, and what other measurements is or are possible on this Doppler profile to estimate LV function?
My apologies, I didn't look at the question. So we can estimate the LV systolic function from the dP by dt function from a mitral regurgitation profile. That's given the presumption that the LA pressures are low and they stay low throughout the mitral regurg, so that the profile can estimate the LV pressure rise. So what we're going to do is we're going to check the time interval between 1 centimeter per second and 3 centimeter per second of the MR profile, and 32 divided by the time difference between 1 and 3 centimeters will give us dP by dt. And if it's more than 1200, then it'll be normal. If it's less than 1200, then there are grades of mild, moderate, severe LV dysfunction. And the next question is, what other measurement is possible from this Doppler profile? Can be estimated.
Sorry, I'd use that dBTT. Would probably be the first one. We can make an estimate about some of the LV function just from this Doppler profile as it stands. Is there anything in that profile that tells you anything about LV function?
So, I mean, if the MR velocity is high,
yep.
In that situation, the LV probably has mild, maybe moderate dysfunction. In case of severe LV dysfunction, the MR velocity probably would be, no, sorry, I'm probably not getting this right. What are the measurements possible?
That's okay, we'll move on, we'll come back to that.
Sure, okay.
This is the last one. What about this?
So again, okay, so we've got a pulse wave Doppler profile. So this is an apical 4-chamber view with the pulse wave gate in the mid LV cavity. And we're seeing a pulse wave Doppler profile, which looks dagger shaped and has end systolic peaking, which makes me concerned for a mid cavitary obstruction.
And what causes that?
So again, left ventricular hypertrophy can be a cause. Hypovolemia, hyperdynamic, hypercontractile states can be a cause. So I would basically fill the patient up, with IV fluids and probably reduce the catecholamines.
Sounds good. Thank you.
Probably beta block.
Okay, final one.
Okay. What does the following information tell you in a patient with poor RV function? So we've got the urea creatinine, which went up and is now going down. So on the top diagram, so we've got a subcostal view focusing on the inferior vena cava. Again, looking at the Doppler profile, again, I can't really see where the pulse wave Doppler, but I'm assuming again, it's in the hepatic vein.
Yep.
Okay, so what we're seeing here is systolic flow is okay. No, so we're seeing systolic flow reversal again of the hepatic venous Doppler profile. Then the next one is in, so I can see, so this is basically an hepatic ultrasound, and what we're seeing is the portal vein. And
Yeah, sorry if you can't see, they are labeled. So it's a hepatic vein at the top, portal vein in the middle, and renal vein at the bottom.
Okay. And I'm guessing the pulse wave Doppler is in the portal vein in the middle one. Okay. Yep. So we're seeing what looks like to me hepatopetal flow, which should be normal for the portal vein, given the flow is happening towards the transducer at the top. So again, that's probably normal portal flow.
Okay. And the last one, renal vein?
Last one, renal. I'm actually not familiar with the Vexus and the renal vein profile, so I'll probably, yeah.
Let's take a pause, and I think that's it, and we'll come back. Very nice. Okay, nicely done. A few things to work on, I think, on this, but I think it would have been a pass. But again, not pass well. And I think we've got a few things to just tighten up. So on this first profile, really nice. You're picking, obviously, we're in the RVOT. You could talk again a little bit maybe about the trace. You got a closing click, which tells us that we're in the right spot for it. You've got a low pulmonary acceleration time. I have 120 being sort of normal and above, and as you said, less than 100 being potentially significant. It's dependent on heart rate, so worth saying when, and you wouldn't use this. So I haven't shown you the heart rate, but I use anything less than 90.
60 to 100, yeah.
Yeah, perfect. And then for me, the pulmonary acceleration time is actually about pulmonary vascular resistance. So if you've got a reduced pulmonary acceleration time, that indicates increased pulmonary vascular resistance. And that's a little bit different from pulmonary hypertension that you said. Again, not pass or fail, but again, probably just my own bias. The flying W sign is indicative of significant pulmonary hypertension. Not always severe pulmonary hypertension, but it's often significant, enough to give you those reflected waves that you beautifully discussed. So nicely done. Another question that I thought, as you were talking, I think I could have asked is, what other views can you get this profile on?
So this can be done in parasternal long axis RVOT and parasternal short axis RVOT.
Any others? Because this was actually done, it wasn't done in either of those, but it's not always easy to see. But where else can you get this view from?
Subcostal,
yeah, nice.
Subcostal and anterior tilt.
Yeah, this is really good. So this is a guy who had horrible ARDS, and we actually couldn't get much from you doing in the parasternal, and we got this from the subcostal, which I thought was quite nice. Otherwise, beautiful. Yeah, good pass. This one you smashed. That's excellent. Yeah, so severe TR, significantly raised right atrial pressures, pulmonary hypertension. Very nice. Sorry if I wrote a bit of a dodgy question for this one. What I was trying to get is that you see a couple of things to me on this Doppler profile. So the reason why I've given you that top left image is to show that you've got a central jet. And if you've got a central jet, it means that your Doppler profile can be analyzed for things like Vmax. So if your Vmax, and it's not the best trace in the world, if your Vmax is around about 4 or below, that's indicative of a low cardiac output. And they talk about it being less than, I think it's 4 liters a minute or something. So it's just LV function can be determined if you don't have a high MRV max. That's what I was trying to get at for this one.
Yeah.
And then the next measurement you could make from this would be your DPDT. And the values that I've got are 800 and 1200. So 1200 and above is normal. 800 and below is severely abnormal. And in the middle, who the hell knows? It can be all over the shop. Okay.
Yeah.
Oh, hey, Michael. You haven't left the
Sorry,
ECMO
Mike.
cannulation just to come to this, have you?
No.
They're okay?
Done. Thank you.
Okay, good job. Cool. All right. And then this last one, yeah, you smashed. Again, it's just signs of mid-cavity obstruction with that late peaking jet. I think you said hypertrophy. I was getting a hypertrophic cardiomyopathy, the mid-ventricle variants of that. And signs of hypovolemia. And the last thing is just, again, being pernickety, the right ventricle is pretty big in this.
Dilated,
so it's not always hypovolemia. It can be because the left ventricle is being pushed over by a right ventricle with maybe some LV, mild underfilling or something like that. Yep, nice.
Yeah.
And this one's Vexus. So definitely worth the read up on this. Hot topic. Lots of people are talking about it. Every course I go to for the last year, everyone wants to talk about this. The general thing I have for Vexus is it's good for looking at venous congestion. And so it's good for looking at venous congestion, particularly if you've got some sorts of right heart dysfunction. It's not very good by itself just to try and assess the bog standard patient for fluid status as a one-off. it might be useful as a serial kind of assessment, but we don't have a lot of great evidence for that. So congestion in things like heart failure patients, they've looked at it in renal failure patients, and it might be suggestive of being okay for looking for congestion in those. But the best one is, as do I put it down here, for the patient with RV dysfunction. And so if you've got this rising creatinine or rising LFT derangement and you're looking for signs of congestion, this is where I find Vexus quite useful. So RV dysfunction, fluid balance, sometimes it's tricky to look at in critically ill patients. This can kind of add to it. It hasn't changed my mind too many times, but it's a nice another piece of information. So because I might just show, if you don't mind, I might, everyone, forgive me if I just quickly just pull this up, because I think it's important. So no, this is the good one. This is the best one. How do I make that big? Okay. So hepatic vein at the top, you've normally got systolic flow less than systolic flow greater than systolic flow less than diastolic flow. You then get systolic flow blunting, which is a mild abnormality, and you have a severe abnormality when the systolic flow reversal. So all that, that's the hepatic vein. And that gives you a score which you can have of 0 if it's normal, 1 if it's severely abnormal. Portal vein is normally linear. So what I showed you was markedly abnormal, and it was one of these. I think it's probably this one here. So you can also get it with cirrhosis, but this is markedly abnormal, and it's flow above you. So when you're looking at the portal vein, you just you're going in the side view. You kind of look back a little bit till you find a big blood vessel which is red towards you, and you put your pulse wave Doppler in that. And again, lots of big serrated tooth edges, sign of congestion. If it just looks linear, it's flat, but it's blood flow towards you, so it's the stuff above the line. Okay. And then the last one is the renal vein. Okay, and this is again markedly abnormal, the one there. So the renal vein, it's sorry, I'll quickly show you how you do it. So you put the color Doppler box over the kidney. So you just sort of fan down and look at the kidney on the right side. Turn down your scale so it's super low. Sometimes, maybe enlarge the gator, the pulse wave Doppler gate a little bit. And I'm looking for blood flow somewhere close to where the cortex medulla are. And you just find anything and you grab that. But you grab both arteries and veins. So the arteries obviously got blood flow coming from inside the kidney going out. So that's the blood flow above is the arteries. And then the blood flow comes back down those loops of Henle or the tubular junctions and comes back down towards the center, down to the medulla. And that means it's the stuff below the line that you're interested in, basically. So that's where the venous flow is. And this venous flow is predominantly diastolic. You've hardly got any systolic flow. And again, that makes it markedly abnormal. So what we were seeing on those three was Vexus. It's all abnormal. That's a sign of significant congestion, which is why that patient had such bad renal dysfunction with their RV dysfunction. So you just got to pull fluid off. And that's obviously where we dialyzed the shit out of that patient. Cool. And that's about everything. That's about everything I know about Vexus. I'm sure there's lots and lots more. Cool. Okay. Joe, are you happy? Next one?
Quick question about that, Sam. For the point and shoots, do you want us to also comment on the quality of the study and everything? How brief do you want us to be?
Just, you've got about a minute per slide, right? So, I mean, I think if you're looking at a dodgy image, and we're trying not to give you too many of these, to be honest, but, we're trying to keep the imaging okay. But talk about, I think, for example, on this one, if you don't see a closing click, you might want to mention that. That's a good one to talk about. You can talk about the image optimization could maybe a little bit better. No, but normally the point and shoots are about pathology. But we might specifically give you a really bad one, like we've done once before with ghosting artifacts in there, and say, could you critically appraise this image? So I think if you're more than welcome to bag out the pictures and talk about how you'd optimize them. But normally we'd direct you if that's what the whole question is about.
Maybe leave it to the end. And then
maybe. And often I think we'll also the examiners will direct you. If we know there's a time limit to this, you know, we've got to get everyone through the stuff. If you're going off track, we'll pull you back onto the right way. And that's, you know, maybe that's a badly written question that we, you know, we're doing our best to write them as well as we can. But if we've done it wrong, we'll pull you back in the right direction. Joe, you got the tough one, okay?
Okay.
So it gets harder as we go along. I think I gave this to you last time as well. We'll start with you next time, I promise.
67-year-old guy, immunosuppressed with interstitial lung disease, an ex-smoker, but flu A
Yeah,
positive.
he gave up 2 weeks ago, so I don't know whether that makes you an ex-smoker yet.
He's intubated on mechanical ventilation with high catecholamine support, and this chest X-ray shows significant bilateral infiltrates. Looks like pulmonary edema, but could be pneumonitis. So the parasternal long axis view on the left shows a dilated RV. It's significantly greater than the LV. The LV looks small, but is contracting normally, and I can't see any.
Really sorry, Joe, I'm on call. Do you mind if I take this?
Yeah, go for it.
Sorry, just give me 1 sec. Excuse me. Sorry about that.
That's all right.
You were saying massively dilated RV, and that's what I got to.
Then I said a small, the LV looks small, but is contracting normally. And then I was just going to comment on the lungs, because I can see some B lines there and some consolidation. There might even be a small shred sign just behind the descending aorta there. So signs of infiltrate in the lungs. And then on the right is a parasternal short axis view with a D-shaped septum, which is throughout the cardiac cycle, which is indicative of RV overload and RV pressure overload. So this is
How do you tell the difference between pressure and volume overload?
So pressure, D-shaped septum during systole, and volume is during diastole.
Thank you very much.
All right, so parasternal short axis view, focusing on the RV outflow tract to pulmonary valve, and again significantly dilated RV. That's in the top left, and then on the top right is the pulmonary acceleration time, which is significantly reduced, indicating raised pulmonary vascular resistance. There's no flying W sign there, so that indicates more post-capillary pulmonary hypertension rather than pre-capillary. And then the bottom left shows colour Doppler through the tricuspid valve, and there's some tricuspid regurgitation there. It's hard to see whether it looks like there might be a slight Coanda effect to it, but looking at the continuous wave Doppler through there, it's not particularly dense, but it's quite triangular. So I would be worried about rapid pressure equalization and the severity of the TR. I think that's a subcost. It looks like a cross between either a subcostal or an off-axis apical four-chamber, focusing on the RV, which is again dilated. I can see some septal bounce indicating high RV pressure overload. The RA, it's hard to say whether it's dilated here, but the LA looks like it's dilated, and the LV looks, the cavity looks quite small. So that's fitting with those parasternal images that we saw before, with an LV below tract VTI of 14. So that is reduced. It's normally 17 to 22. So there is some LV dysfunction associated with that, probably due to reduced preloads because of the inability of the forward flow from the RV.
Excellent. Very nice segue to this question.
Yes, so we're looking at the variations between kind of respiration and intraventricular interdependence with these images here. So the left is looking at the LV outflow tract, and you can see that the variation is about 16%. So normally we the variation should be around 13-14%, I think. So that's raised, and that would indicate that there is ventricular interdependence because of the pressure of the RV on the LV.
Why are we measuring it? Is there any other reasons we measure this?
Not that I can think of. I'm thinking of cardiac output, really.
Yeah, absolutely. So cardiac output.
You're looking at stroke. You're trying to assess what the stroke volume is for the patient. So the LVOT VTI gives an indication of what the stroke volume is, which then gives you an indication of the cardiac output, because you time stroke volume by cardiac output.
So why we've got the respiratory pattern in here. You mentioned about the respiratory changes with it. So we're talking about the variation I've told you here between the peak velocities and the LVOT. Why do we measure that?
Because when you breathe in, you improve preload to the right side and reduce preload to the left side because of the movement of the intraventricular septum due to the pressure of the
Absolutely.
RV.
And then the values, does that tell you anything with the values?
It does. It's telling me that I'm trying to explain. So that the variation is increased. So there is. I'll try to put it into words, because normally it'd be around. I think the variation is normally around. It might be 20% actually, but
12 or 20 different things. And what are those papers about, or what do they talk about the 12? What does it mean if it's less than 12? What does it mean if it's greater than 12?
Well, you can talk about whether you need to give a fluid bolus, for example, for the patient.
Beautiful. So, fluid responsiveness.
So
nice.
Fluid responsiveness.
So is this patient fluid responsive?
No.
Why? Because it's greater than 12.
It is, but I'm concerned about the RV effect on the patient.
Excellent. Well done. Perfect.
So
we went ahead and did this.
Yeah. So that's a passive leg raise test measuring the stroke volume pre and post as an indication of whether the patient's fluid responsive. And as you can see, the stroke volume's basically the same between the two, so not fluid responsive.
Excellent. My last question is how do you define and diagnose cor pulmonale?
So cor pulmonale can be acute or chronic, and it's both bilateral. It's both right ventricular and left ventricular dysfunction because of raised intrathoracic pressures or right heart pressure or PEs, for example, for acute cor pulmonale. And then chronic cor pulmonale is biventricular failure as a result of chronic LV dysfunction leading to raised pulmonary pressures and then RV dysfunction.
So is that diagnosed purely on echo then?
No, so there's clinical, so you can take a history, do examination. So clinical findings would be signs of right heart failure in the chronic cor pulmonale, which would show pleural effusions, raised JVP, peripheral edema, with blood tests to suggest end organ dysfunction and venous congestion. So raised LFTs and an AKI.
Nice. And actually, that was where we had that from that patient, but I put it in the other question, forgot to delete it. Nice. Smashed it, Joe. Great job. I think we got tied up in knots a little bit here. The word I was looking for, all the tick was fluid responsiveness. Yeah. So normally we're looking at that to look for fluid responsiveness. 12% is the magic number for LVOT variation that says you're fluid responsive if you've got it, less if you don't. LVOT variation, they say anywhere from 10, 12, 20%. For the LVOT variation, you've got to have decent tidal volumes. So, and this was all about, you get false positives when you've got an echo that looks like that.
Yeah. False
positives, because like you said, because of the ventricular interdependence. So I think it's probably just I wrote a crap question rather than you didn't know it. So excuse me. and they love asking this in EDEC exams if anyone's doing those. So yeah, false positive of LVOT variation when you've got a big RV. So don't give fluids in this situation. If anything, you need to take fluids away, and that's why it's important to go ahead and do that, in my opinion. You know, if you've got signs of a horrible RV that looks like that, you've got signs of those kind of congestion, you need to be pulling fluid off these patients. And I don't have any evidence to support this next statement, but I do dialysis early on. Unless they're very, very responsive to frusemide, I just put them on dialysis and pull fluid off them, correct their acid-base disturbance to try and reduce the afterload and reduce the preload on the RV.
Yeah, same.
Cool. Oh, Michael, you might have actually been here for this patient. Anyway, go for it. This is the last one.
So 7-year-old in hospital, MSSA bacteremia with a bioprosthetic valve, aortic valve 11 years before, increasing oxygen requirements and hypotensive on catecholamine support, and he's had a toe. Okay. Can I just make my images big? Hold on 1 second.
Sure.
So we're a mid-esophageal 4-chamber view. I can see immediately that the LV appears distended with at least moderately impaired systolic function. There's a color wave Doppler on the right-hand side of the screen that demonstrates mitral regurgitation. It's hard to say if it's mild or moderate on this view. What further images would I like to evaluate the severity? So I'd like to see the mitral regurg in multiple planes. So both the 60-degree view as well as a 120-degree 3-chamber view, just to see if that jet is in any other directions that I can't quite see at the moment. It would be good to see a continuous wave Doppler as well as views of the pulmonary veins with pulse wave Doppler to assess pulmonary vein flow. They are the main things I can think of to assess the severity. In terms of the chronicity, the left atrium, it's really hard on toe, but probably is dilated.
Is there anything else that you could determine on this right pitch? You talked about the mitral regurgitation. Is there anything else?
I'm not sure if it's an artifact or not. There's an area of colored Doppler, which looks like it could be, adjacent to that prior prosthetic aortic valve. I'm not sure exactly what it is in this view. It's a bit hard to say. I can't see the bioprosthetic aortic valve moving very well on the 2D image, so I'd be a little bit worried about. We'll move on. Okay.
So these are, you asked for continuous wave and pulse wave Doppler. We've got, what do you think from these? These are for the mitral valve.
So the peak E wave velocity on the inflow is greater than 1.2, so that makes me worried about significant MR. And the continuous wave jet is not completely filled in terms of the density, which doesn't fit with severe. But the pulse wave Doppler in the pulmonary vein, I can't see P waves. So I think that there is no reversal, but there's S wave blunting in the pulmonary veins. So these things kind of fit with moderate MR, but in terms of this patient who's hypotensive, that peak E wave velocity of 1.4 or even higher is quite concerning for a pretty significant MR contributing to the decompensation at this stage. I'm pretty worried about the forward flow through that bioprosthetic aortic valve too.
Nice.
What further images? Okay, so this is primarily, I suppose, looking at the aortic valve. I can see one of the aortic valve leaflets. This is the bioprosthetic aortic valve. I can see one of the leaflets moving well. I can't quite see the others. It looks like there is the color wave box isn't in the perfect location, but it looks like there is some regurgitation of this valve, and it looks like it's paravalvular regurgitation, which makes me pretty worried about dehiscence of this valve. It doesn't look like it's rocking. There's no significant motion of the valve in these views. I can't see any significant aortic root abscess and thickening of that aortomitral cushion.
Anything else unusual about that aortic regurgitation?
I mean, there might be a second eccentric jet coming from sort of...
That's excellent. And tell me what other views would you want to try and determine the severity of this aortic valve dysfunction?
It would be great to see a deep transgastric with a continuous wave through that aortic valve, or even a gastric 3-chamber view at 120 degrees to try and see a continuous wave Doppler to see some things like the pressure half-time, which could be helpful. Even a short axis view through the valve would help too. So a 45-degree view, or even a biplane view at the current angle, to see if the location of this regurg, because it seems like there might be multiple regurgitant jets.
Anything else?
I mean, it would help me with chronicity to see measurements of the LV to see if it's dilated. I can't think of anything else at the moment. I'd like a pulse wave Doppler in the descending aorta. So this is a pulse wave Doppler in the probably in the descending aorta.
Yeah, descending. Sorry, I should have said that. Yep.
2-chamber. Oh, sorry, a long axis view. So this demonstrates. It does demonstrate some diastolic flow, but I don't think it's greater than 0.2 meters per second. So I don't think that this is consistent with severe regurgitation.
So where do you measure the 0.2? What's the 0.2 value referring to?
End diastolic flow.
Excellent. Okay, the sudden profound deterioration 2 days later, we repeated the toe.
Okay, so this looks pretty bad. This is another midesophageal sort of high 4-chamber. It demonstrates abnormal motion of the mitral valve and the aortic valve. It looks like there's a mass on the mitral valve leaflet and potentially complete dehiscence of that mitral aortic cushion, with potentially a significant defect between the LVOT and the left aorta. Which of the mitral valve?
Yeah.
Is that what you're talking? The anterior mitral valve leaflet?
Yeah, and which
probably at A1.
Okay.
You can see on this color Doppler that there's an obvious defect in the base of the leaflet insertion of that anterior mitral valve, probably at A1, as well as some. Yeah, that's what I can see.
Yeah, nice. What's your management from here?
And call some surgeons urgently. This person needs an operation and some antibiotics.
Yeah, very nice.
Yeah.
That is that. All right, let's quickly go through that one. Okay. So yeah, excellent, Michael. Really, really nice. Few things to pick up, right? We talk about, we ask it, relatively frequently, I guess, this kind of broad question about, we'll show you one picture of mitral regurg and then say, what other views do you want? Just work on a kind of pattern where you can try and get that out in like 45 seconds. So what I'd encourage to do is, you didn't say anything about 2D and you didn't say anything about the mitral valve E-wave VMAX. So just try and keep it systematic, where you talk about, 2D, if there's a massive bloody great hole there, it's probably going to be severe. If there's a massive 2D defect, that's going to point more towards severe. You want multiple planes of analysis, very nice, multiple color wave Doppler boxes as you can go through it. So yeah, just have a nice little sort of pattern. If you can mention some of the limitations with it as you go through it, I think that's great. But again, 45 seconds is normally what we're after, and you would have passed, right? The only thing you didn't mention was that mitral valve E-wave velocity in the 2D. So I still think that would have probably been a pass, but you can move it through. You did something really nice in that, which I wanted to talk about in relation. I forgot to do it for Joe's one on the last one. You talked about the severity of the mitral regurg in the clinical setting, which is this guy being on some catecholamines. In the last one, Joe, I forgot to mention, you talked about a normal functioning or normal contracting left ventricle, but we forgot kind of to mention that this guy is on, he was on truckloads of catecholamines, wasn't he? He was on like NORAD, vaso, and dobutamine, I think. So again, in that setting, the heart should be beating much faster. And the mitral regurg severity, you were talking about that in the context of the clinical pattern, and also looking at how well, because if you've got acute MR, that LV should be going hell for leather. So just don't forget about the clinical context. That's why we're giving it to you in the STEM. And then, Michael, the only thing about the aortic valve regurgitation I was getting at was it's eccentric, right? So the reason why I was asking you about why what other information do you want? Well, all those things you're talking about, like the continuous wave Doppler and the gastric view, they're not going to be that useful because you've got this really weird eccentric jet, which in the setting of that MSSA bacteremia is someone that's going to have infection till proven otherwise for me. You know, that's the big thing for infective endocarditis for me. You know, it gives you really weird, eccentric, chaotic jets that don't follow the normal pattern. So you often can't do standard continuous wave Doppler. You need other things. So for me, the things we'd look for would be diastolic MR, acute severe mitral regurg, diastolic MR and the pulse wave Doppler in the aortic valve. Please don't forget that. I feel like we've been through that a lot together. It's really important. And the reason why it's important, because all the other things you mentioned are a bit shit when you have acute infective endocarditis and a valve that's about to fall apart that was then infecting other parts of that mitral valve. So hence the importance of having this systematic approach, but understanding why some of the standard things don't work, which is why you need to look at your pulmonary veins for your mitral valve, why you've got to look at your ascending or descending aorta with your aortic valve, particularly if you've got valves that are bioprosthetic or mechanical, which make them harder to look at, and looking at your hepatic veins with your tricuspid regurg. So, those are the ones that you can't fake. They're, if you've got them, you can see them, you can say that that's abnormal. And, that's why I bang on about them every time. Drew.
Yeah, thanks, Sam.
Pleasure.
Just a question with the nomenclature for the exam, Sam. With the question, it was what other views? And in my head, I was thinking, well, the 4-chamber view, 2-chamber view. You've used modes before, and what other modes would you use? And that's like, your 2D color, CW. Yeah.
Did I say that? Yeah, that's definitely, I think hopefully the other examiners have picked that up. That's exactly the kind of thing I'd get wrong. And what I was after was, as everyone went down, was just what other things you have to look at to try and tell the severity. Sorry if I got that wrong. So I think hopefully that will get picked up. If it's not clear, the examiner again will point you in the right direction. Okay. So because we'll have a marking grid that won't have anything about all the different views. It would all be about the mitral valve, and hopefully normally it's Richard Strickland that picks me up on that stuff and doesn't let me get away with writing dodgy questions.
But the questions, if you say views, that's the other.
That should be views,
and it's modes when you say what other mode?
What other?
Or how else?
I would say normally if I could write it again. Now you said that, I'd put something like, what other information would you like to obtain to determine the severity of the mitral valve abnormality or the aortic valve abnormality or something like that?
Thank you.
Nice one, guys. Hope that was useful. See you next time. I'm going away for all of July. I'm really sorry. So, I'm not sorry. I'm sorry. I'm very happy I'm going away. I need a break. But it means I'm going to find people to fill in to do the Viva practice with you. They'll all be ex-DDU people, so they should be really good at what they're doing, or cardiologists. But apologies to be away, and I'll be back in August, and maybe we'll have one session before the exam on the I think it's on the 7th of August or 5th of August. So, but I'll see you for next week.
Thank you. Have you got Spider-Man on your scrub?
Yeah, it's Fun Scrub Friday. It's how we artificially pretend we're having fun. But yeah, that's Spider-Man, because it's all about your spidey sense. You got to have your spidey sense tingling. It's a gestalt. Yeah, I don't know.
Love it.
Sam, could I ask? Sorry, Lucy Docker here, and I'm so sorry.
Hi, Lucy. Hello, how do you do? Nice to meet you.
Nice to meet you. I'm just wondering, I got an email from you during the week. This is just a practical question with written DDU questions.
Sure, and you're sitting this August, are you?
I'm hoping to, and I wasn't able to click into the link, so I'm just wondering. I just wondered, are we supposed to be able to click into the link, or who can I contact about getting access?
What link was this for?
Sorry, I received an email from you 3 days ago titled Written DDU Questions number 11.
Yes.
And there's 2 links, and I can't click in.
Wow. Lots of people have been weird things from my email. I will send you that again. Is anyone else getting really weird emails from me?
I couldn't access it.
Sam, I had the same problem. I think you actually tried sending it to me again, and it seems to be some sort of encrypted email that I can't open.
Yeah.
Maybe that's something weird. I'll try again with a different email. Let me have another crack at that.
Thank you so much.
No problem at all. Well, nice to meet you, Lucy. Lucy, where are you working?
at the Alfred.
Alfred, fantastic. And you're studying the DDU this year, so when you're no longer hoarse, it'd be great to try and do some Viva practice together.
I didn't think today was the right day to volunteer.
No,
Thanks.
no,
Yeah.
no problem at all. Best of luck. All right. Nice to meet you. I'll see you later. Rob, did you have a question?
I
Or
do
you-
have a quick, I have a
Sure.
strategy question.
Yes.
Are we able to write down on a piece of paper during the Vivas? Just because I get
Yeah.
distracted by the images and forget what the clinical information even was
totally.
sometimes.
Yeah, no problem at all.
Yeah. Okay. Cool.
Yeah, definitely. So whatever you need to do, but as I say, we've got a time frame, 40 minutes, 7 or 8 questions. Don't take too long. I have to do the same thing. I'm writing down notes as I listen to you because I can't do 2 things at once. So yeah, 100%. But just keep it fast, and keep the cadence going, and keep that banter with the examiners, that kind of stuff.
Yeah. Okay. Thank you.
Cool. See you later, guys. See you next week. Bye.